Thank you. I wanted to congratulate the organizers for such a great meeting. This is my first time at this meeting, and I'm very impressed. So, Jafar, very good job. So I'm going to present something that's a little bit provocative. It's a post hoc analysis from the VISION trial. The VISION trial is basically an OCT-guided atherectomy IDE PMA application trial to obtain approval for the device. Here are my disclosures. So most of us do, as you've seen cases today, perform lower extremity interventions, mostly based on fluoroscopic images. We do mostly single or maybe two angles, and we assess the plaque, and we assess what we need to do based on that. We rarely do intravascular imaging. So the question then arises, does intravascular imaging add to not only how you treat the patient, but also will it alter the outcome? Another way to look at it is not only does it change the outcome for the patient, but can you reduce fluoroscopy time and radiation dose and contrast use, and does that then improve your own outcomes? So you're in the lab much shorter time. So even when you do procedures, I think you have a difficulty assessing plaque in these patients. And even if you do atherectomy or directional atherectomy, most of the plaque that you extract is very small compared to the total plaque burden that exists in the artery. So what we looked at in the post hoc analysis of the trial is something we learned on the coronary side, where we actually did a great job in treating these vessels, and then we treated with a drug-coated platform in the coronaries that was either a drug-coated stent or in the earlier days radiation therapy. And we realized this concept of geographic miss, initially described by Ron Waxman in the wrist trial, as well as Patrick Sarais, and mostly what we saw was what we call candy wrapper stenosis. So basically, we treated the entire lesion. The lesion looked great, but at 5 millimeters on either side, we developed restenosis. And this is another trial that shows OCT-guided reassessment of that same concept of restenosis, where restenosis occurs at the edges, but not in the center of the treated segment. So why is that? And one of the possibilities is that we're treating the lesion, but we're not able to assess the length of the lesion. And we noticed this in the VISION trial. So in the VISION trial, we enroll patients based on fluoroscopic lesion length. And generally, in this case, you can see the lesion length is this length of the occlusion, maybe a little plaque proximal and distal, but the total length of the lesion is probably 6 centimeters. When we actually put the OCT catheter in and looked at different segments of the vessel, those plaque extending up and down that vessel. So the concept today in the coronaries is that you stent from normal to normal. So you deliver drug from normal to normal. And here, we're treating just the disease segment that we see fluoroscopically, but as we extend our visualization by OCT, we're now able to treat a much longer segment. So does that impact the patient outcome? So here, we describe that in longer lesions, we are better at estimating lesion length. But in shorter lesions, just because our eye sees the most narrow part, we often undertreat the segment that is truly diseased. And what may happen is that may alter TLR. So in this very small patient population, we looked at patients who actually were treated based on short lesions, fluoroscopic guidance, and we saw that most of the TLR occurred in that population. But in the population that we actually looked at and treated the OCT-guided length, as we got familiar with the device and what we needed to treat, we realized that we had no TLR, and when we extracted and removed all the plaque that we needed to remove. So in conclusion, there is a diagnostic gap. There is a gap between intravascular imaging versus OCT-guided imaging in this case. And if we do intravascular imaging, we will treat a lesion truly to its length that exists rather than what we assess by fluoroscopy. And I think that by doing that, we may improve the outcome of the patient in the short term as well as the long run. Thank you very much.